Hey folks, my name is Dr. Amy Pearlman. I'm a board-certified urologist with expertise in sexual, hormonal, and genitourinary health, and I'm coming at you once again from Grapevine, Texas at the Sexual Medicine Society of North America meeting, our annual meeting, and I have Dr. Ryan here with me today. Ryan and I connected last night, just hanging out after some dinner events, and I have him here today to share some of what it's like to be on the hot seat. But why don't you first start by giving yourself a brief introduction?
Yeah, I love it. Thank you so much for giving me the opportunity to do this. My name is Dr. Ryan Griggs. I practice on Monterey Men's Health / Salinas Valley Urology. I'm a board-certified urologist, fellowship trained in men's health. So I care a lot about quality of life. And I love that you have me here today.
Yeah. And I didn't really know much about the California geography. So, like, where are you at in California?
Oh, yeah. So where San Francisco is, 2 hours south on the coast.
Okay. Excellent. So I have Ryan here with me today, and he's been discussing some very interesting and I don't know if you'd say polarizing or some heated discussions at this meeting when it comes to penile implant surgery and infection prevention. So first of all, talk to me about what it's like to be on the hot seat when you get a lot of people coming up kind of like not picking at you, but like asking you like serious questions about the work that you're doing.
Oh, definitely.
Yeah.
So when you finish your talk, there's always the impending doom, right? Where the line starts going. It's a domino effect, right? You have Dr. Moore.
Well, I guess that's good, right? Definitely. Because when people ask questions, it means your subject matter matters, right?
100%.
Yeah.
100%. So quite anxiety provoking, sphincter tightening, whatever you want to say. But being on the hot seat, as long as you feel comfortable, I think it's manageable. And if you can know what you know and say what you don't know, then you're fine.
Yeah. Okay, so talk about like this topic that everyone's kind of talking about here.
Yeah, so penile implant infection, paramount importance. Such a minimal risk when you're really counseling patients to get this surgery, 1 to 3%, 5 to 8 if diabetics, right? So we're talking a small risk. But we're trying to prevent that because it's devastating for the patient, right? If you do nothing, no salvage, no vacuum, and you just remove that penile prosthesis, 2 to 3 centimeters is an average length loss. That's over an inch. And some men may not have that to spare. So it's of critical importance, and that's why we're doing this research in comparing antibiotics versus an antiseptic, hoping to get some more data that supports using antiseptics versus antibiotics, because as we know, antibiotic resistance is on the rise.
So what's the difference?
The difference between an antiseptic and an antibiotic. So antibiotics usually work over time to kill bacteria. Antiseptics work on contact and layer, and they have what's called kinetic kill time, as opposed to a zone of inhibition, wherein you have a Kirby-Bauer test. And you put down the antibiotic and you grow the bacteria, you have an elution of that antibiotic and that kills the bacteria, giving you a zone of inhibition, telling you that the antibiotic kills that bacteria. A antiseptic is usually broader spectrum. And for example, chlorhexidine gluconate, 0.05% is what we're using now. That kills some selected viruses, fungi, candidal species, and a broad array of gram-negative and gram-positive. And there's no known resistance to antiseptics, unlike antibiotics, which is why there should be a move back to this, right, regardless.
All right, so there are two camps here, right? There's like the antibiotic and the antiseptic camp, and you're in the antiseptic camp. But why is this like a head-to-head thing?
It's a head-to-head.
Can you answer this? Why is it difficult? No. Or maybe is it not difficult to answer the question?
It's difficult to answer the question because whenever you do something for a very long time, that's what you're comfortable with. And every surgeon, you could argue, does a thing because they were taught that. They feel comfortable with it and they want to continue that. And then when things shake it up, it's hard to let go. And it's easy to be a scapegoat and blame the new thing and not consider confounding factors, operative time, patient factors, surgeon experience, et cetera.
Yeah. Well, I think what kind of changes behaviors, right, is like, so we try new things. So let's say I'm trying like the antiseptic, and I'd used the antiseptic before and I find it very valuable, right? Is what if, the patient that we're trying this new technique on or this new therapy, that patient gets an infection. Like sometimes all it takes is one bad outcome where we say, I know this could have happened regardless of what I did, but I just don't want to do that anymore because that felt really bad for me and the patient. Like how much do you think that is playing a factor?
I think that's also plays a huge factor because we all want to have happy patients, especially in penile surgery or enhancement, right? So it's very hard to let that go and look prospectively at things. And that's why we designed this prospective study with Dr. Levine and Dr. Cartman to help answer that question. Certainly not definitive. Definitely need more studies for that. But it's very important to push the ball, because the CDC actually just released a report of 14,000 new infections of an E. coli that's resistant to carbapenems.
Oh my goodness.
And beta-lactamase.
Yeah.
So we have no known antibiotics currently to treat this bacteria. 14,000 documented infections within the United States. And what happens when that starts with penile implants? There's been research presented at this meeting, for example, of increasing doses of antibiotics. We can only increase, we can only change so much before we run out. So that's why we should change over.
Yeah, so that's definitely a hot topic. And I'm sure, like all of our meetings, this conversation is going to evolve, and certainly an exciting topic. And I think it's probably a difficult area to study as well, because in general, infection rates are low. So you kind of have to like pool quite a few people together to even test a hypothesis.
Correct.
Yeah.
And I think that's what the Pump Collaborative has done.
Yeah.
And I think they do a very good job at looking retrospectively, because they have a 14 cohort large tertiary center referral population. I think that's wonderful, but albeit it's retrospective.
Yeah.
So yes, you are correct. So with our study that we presented as perspective, it's the only and the first retrospective study looking at a comparison. So that in itself is very valuable. It may not be definitive, but over time, we are still accruing patients, so we can answer that question further. And we did what's called a non-inferiority study, which allows us to have a smaller sample size to have statistically significant outcomes, right?
It's kind of like a catch-22, because like you want the patients to be able to test your hypothesis, but then you're asking for a complication.
Right. And then you have the camps where you have apples and oranges, for example, where this retrospective data is looking at both revision and de novo implant surgery. And we are presenting only on de novo implants. So we already know revisions have an increased risk of infection, up to 18%. With a washout, you can reduce it to 3%. But you can't compare the two in that regard.
So you and I last night were actually discussing some other novel technology that you're working on. Can we get into that a little bit?
Yeah.
With vasectomies?
Yeah.
All right, why don't you lay the groundwork here?
Wow, I love that. Thank you. That was good marketing for this seal vasectomy procedure. I love that. Thank you. Yeah, and so when I was a fellow with Gerard Henry, I had the opportunity to get involved with Signati. So Signati Medical has a proprietary generator and handpiece that we're developing to have a sealed vasectomy technique. What does that mean? That means a vasectomy from extrascrotal, right? So outside the scrotum, where traditionally non-scalpel or open vasectomy, you have to open the scrotum, deliver the vas, cut the vas, put them in, and then have an incision. So the idea behind the procedure is to have a faster, easier, simpler procedure that all urologists can do and maximize patient outcomes, as well as decrease provider burden.
So you're saying you wouldn't even have to make an incision?
That's correct.
Okay, but really quick here, okay, because the no scalpel technique, I love the market. I mean, I have that on my website too, the no scalpel technique. So what do? You kind of like, look, there's like a little rip and tear.
It's a misnomer.
So like, I mean, are we saying like there's no penetration into the skin, or are we saying it's a similar thing where you kind of poke and you spread?
No poking.
No poking technique.
No cutting. No poking, no cutting. Similarly, you have to isolate the vas, the most difficult part of the procedure.
Yeah.
The proprietary clamp holds that in place. Proprietary electrode goes around that clamp. You activate the impedance pedal. Takes 20 seconds, and it seals the skin and excises the skin and the vas while sealing the vas segments. Then that wound is reapproximated either with surgical glue or one stitch.
Wow. That's freaking awesome.
So that would be truly a no scalpel vasectomy.
Wow, I love that. So where are you guys at in terms of like the studies, and when is this going to be available? When can I get it from my office? That's what I want to know selfishly.
Same. I can't reveal too much.
Okay.
But what I can say is that we did all of the animal studies, started in rabbits, dogs, pigs, and then we completed a 8-patient safety and efficacy study at LSU New Orleans with Dr. Mutter. All 8 patients had no wound complications. The caveat to that is that the FDA required us to do it with a scrotal incision. So you still had to deliver the vas. They wanted to know if the sealing tool was efficacious. The patients were followed over time, 90, 180 days. Azoospermic at 90, no need to follow up. Not azoospermic at 90 days, follow up at 180. By 180 days, all 8 patients, no wound complications, azoospermic. Those results were just presented at the meeting today.
Yeah.
On yesterday with Dr. Mutter. So we take this to the FDA, and the FDA now is asking for more prior to approval. So what they're asking for is a comparative. Yeah. Who doesn't want more? Give me more. Give me more. So FDA now, because non-urologists perform this procedure, 3 to 4% of vasectomies throughout the country are performed by family practitioners, for example. They want a training program for non-urologists. 2, they want a comparative study. No scalpel vasectomy versus sealed vasectomy procedure. We don't know the amount of patients they want. It's unknown. We'll have about 4 or 5 doctors and doing dozens of procedures each, so it will not be difficult to accumulate those patients. The problem is the post-vasectomy semen analysis. As we know by American urological guidelines, you get the first semen analysis after 25 ejaculations, 8 to 16 weeks. That's 2 to 4 months. So 30 days to develop a protocol. They then have 60 days to approve that protocol. Then the study goes. So really, we're looking at least a year, year and a half. But we all know things can change, obviously.
Yeah.
But it is certainly much closer than it has been. I'm very excited about it.
So let me ask you this, because, a vasectomy procedure is, for some practices, like the bread and butter of what urologists do. Why do you think, what would it take for urologists to change this practice? I mean, we think that, there are new technologies that make things like easier and more efficient, and yet it is so darn difficult to change behavior in healthcare providers. So who do you think would be interested? Yeah.
The number one thing that changes provider practice, in my opinion, is patient desire. We all have those patients that come in asking for Rezune, or I want a Titan penile implant, or I want aquablation, or et cetera, right? So they have a desire, and patient desire really drives provider service, in my opinion. Falafel, for example.
Yeah.
So if you have the population that wants that procedure, it's being marketed. Yeah. They're going to see that. Men already have some level of anxiety about that procedure. If they're seeing a faster, simpler procedure with less complications, for example, pain is the most common concern, then they're going to be asking, and either you provide that or you don't. Yeah. And if you don't, they may find somebody who does.
The other sort of logistical thing is, for a few years I was working at the University of Iowa, and pretty much like any tool that I needed, in terms of like instruments in the operating room, like we could get, and there were great like vasectomy sets. And now I'm in private practice and I have my own clinic. And so, in order to offer, like vasectomies and really good instruments, you need like an autoclave. But like the process of even having like an autoclave in clinic and a sterilization sort of operation going on is like a very big deal, right? And so when I do vasectomies, I, for the most part, am using disposable instruments, which are not as good,
Interesting. Okay.
As that you would sterilize. Sure. And so whenever I'm doing a vasectomy, I actually like borrow sterile supplies from a colleague of mine.
Sure.
Because I don't want to have to do that whole process of sterilization in my office. That's my barrier. That's why it makes vasectomies a little bit more painful for me, because of the instrumentation.
Sure.
Yeah.
And so definitely coordinating supply exchange is difficult. Yeah. I actually fall into that same issue with penile prosthetics. When I do a penile prosthetic at the surgery center, I do the vast majority of them at the hospital because there's a lower infection rate. When I need to transfer my tools from this to that, there's always some red tape to go around, and that's very frustrating. And so as you said that you were using disposable tools that were not as good, I completely understand that. And the great thing about this is that the hand base is disposable. You use a new one for each patient. You don't need to worry about sterilizing it, and you don't need to worry about the sharpness of the instrument or something like that to penetrate the scrotum.
Yeah, awesome. So you're got your hands in like 2 very interesting topics. What else are you curious about?
So I'm very curious about filling penile implants with alternative substances.
Oh, that's interesting.
Because I work with Dr. Cardman, and I love that he is so innovative. and kind of pushing the bar and making everybody kind of feel uncomfortable. Most high volume implant surgeons have been filling with saline for decades, since the 70s. So it's a transition from IV contrast because of the hypertonic solution. So another thing we've been doing for eons and then not comfortable going on to do something else. So his novel idea, which I think is fantastic, is the Kinder Egg effect. And so if you're not familiar with the Kinder Egg, it's a child candy. My daughter loves them because
What does it taste like?
well, it's kind of like a creamy substance with a cocoa ball.
Okay.
One half is the candy, the other half is a surprise. And usually it's a toy that you have to assemble. So that's the Kinder Egg. That's the surprise. And so what is the surprise? Biofilm gets a surprise. There's an antiseptic on board. So what we've been doing for the past year or so is at 2 sites, Dr. Henry and Dr. Carbon have been filling their implants with Irricept. This study was completed in vitro first through a Coloplast-sponsored study, and that was shown not to be costed to the device after keeping the implant at body temperature for 6 months. That data was presented last year. So then we went on to do the clinical study. And so in this clinical study, we've had about a year of data. And with the follow-up is about 6 to 7 months or so after there's been no mechanical failure of the devices. So retrospectively, that allows us to propose that this is mechanically safe for the device for a year within the human body. What we don't know yet, is it going to achieve the hypothesis that we want? Because we all know we are composed of mostly bacteria. So we have our own microbiome. Then we put a device in through an incision that allows outside bacteria in. Like Dr. Reed is so famous for saying this, we cause infections. But I think it's a complex relationship between patient factors and surgeon-induced factors that lead to this biofilm formation, technically inert while the device is in there. But as soon as you aggravate that through revision surgery, that activates the bacteria. Now, what if those bacteria are pre-treated with antiseptic, because we're only doing this in Titan Coloplast implants? Number one cause for mechanical failure is what? Tubing rupture. So instead of leaking saline, where resistant organisms actually can proliferate, such as Serratia, such as Pseudomonas, that can be very resistant to antibiotics, can proliferate in saline where others cannot. So there's concern for increased revision infection. So what if those organisms are pre-treated because that fluid has been sitting there, even though the patient has no symptoms or signs of infection? You go in at revision surgery and now your cultures are all of a sudden negative, as opposed to it being polymicrobial, which is most common. So that's really what we're trying to...
So the patient would still undergo a revision surgery, but it would be, okay, let's explant, reimplant versus having to do this big washout and treating an infection and then going from there.
Certainly you would definitely do a washout regardless to reduce risk of infection. But do we have a lower risk of infection? Instead of being up to 18% in revision surgery, do we move the needle down farther?
Awesome. Well, very exciting work that you're doing. So we'll have to stay tuned to the AUA meeting and the next SMS meeting. I'll definitely see what you're up to and when these devices may be change practices.
100%.
Become commercially available. So thank you for tuning in for Pearls and Perspectives. Ryan, always good to see you.
Thank you so much, Amy. I appreciate the opportunity. Thank you so much.